Now, finally, I want to talk about some of the new and exciting treatments that are coming along for myeloma. Now, we have made a dramatic progress in the past 10 to 15 years, particularly so in the past 5 years, with several new drugs that have been approved, and there are several new exciting ones that are currently going through clinical trials. So among the approved ones, the more recent ones have been the monoclonal antibodies like Daratumumab or Darzalex, Elotuzumab or Emplicity, and then there are proteasome inhibitors called Carfilzomib or Kyprolis that's given IV, Ixazomib or Ninlaro, which is a pill. There are drugs called histone deacetylase inhibitors or HDAC inhibitors. It's the panabinostat or Feridac that is not very often used but still available and approved. There are drugs that are in clinical trials. Quite exciting are the CAR T cells. There are others called BiTEs or bispecific T cell engagers. There are monoclonal antibodies against the BCMA, which is a protein on the myeloma cell. And then there are small oral drugs, small molecule drugs called Selinexor and Venetoclax that are going through clinical trials. Many of these are very exciting and appears to be quite effective, so we hope to get these into the clinic in the near future. In particular, I just want to just highlight the immune therapies. I know many of you heard about this. Many of you may have received it. In particular, there's CAR T cells, which is a chimeric antigen receptor T cell. What they do is, again, just to refresh, T cells are the immune cells that destroy these cancer cells. The problem in myeloma is that, one, the T cells are often kind of put to sleep by the myeloma cells, and two, because of that, these T cells fail to recognize these myeloma cells as foreign and cannot find their way towards the myeloma cells. So one of the ways to overcome this problem is to take those T cells from the patient, use a genetically engineered, what we call a T cell receptor, and put that into the T cell, and then put these T cells back into the patient. That allows these T cells now to target the myeloma cells, go towards the myeloma cells, and specifically kill the myeloma cells. A similar approach, a similar strategy, but a different approach is taken in the case of the BiTEs or the bispecific T cell engager. So instead of taking the T cells out and changing them, what this does is inject the patients with an antibody which at one end can recognize the T cell and on the other end can recognize the tumor. So you can think about it as a little wire connection that pulls the T cell towards the myeloma cell, and essentially once it gets close, the T cell is able to recognize the myeloma cell and kill it. Advantage of this is you don't have to take the cells out, wait for it to be converted, but instead you just give the medication just as if you would give any other medication. Now, the other approach in myeloma that has really changed how we think about this disease is the concept of minimal residual disease. As is shown in this figure, what we know is that the more myeloma cells we can eradicate with treatment, the lower the M spike gets, the longer it takes for the myeloma cells to grow back. And our hope is that by giving effective treatments, especially in combinations, we can get these myeloma cells down to such a low level that the immune system can take care of whatever is left behind, either with or without some of these immune treatments we just talked about. Now, there are clinical trials starting to look at, can we use this MRD testing to decide how long somebody needs to be on a treatment, whether the treatment needs to be changed, or we need to do something different for these patients. The other approach that I think holds a great promise is to try and use all the different drugs we have in multiple drug combinations to try and get rid of every myeloma cell. What we know is that the myeloma cells in any given patient can be quite heterogeneous. They can be multiple groups of what we call clones, each of which may be slightly different from each other. So by using 3 different drugs like bortezomib, lenalidomide, daratumumab, and dexamethasone in addition, we hope that maybe we can get rid of multiple of these clones and get better benefit. What we know right now based on the early trials is that we can get very deep responses. So for example, here almost 100% of the patients with these 4 drugs have gotten to a complete response, which was unheard of 10 years ago. Now the question is whether these deep responses will translate to myeloma staying longer away and actually improve the lifespan is something that we are currently looking at. Now the final concept I want to talk about is one that I think we are all very excited about, is can we actually cure the disease by intervening very early? Now remember, we talked about the concept of smoldering myeloma as a phase of transition between the MGUS and myeloma. And if it's a stage of transition, can we identify the people who are likely to get myeloma? And if we know those people with high degree of accuracy, can we just treat them like myeloma before they actually become myeloma and actually have good long-term outcomes? So the Spanish group did a trial where they combined carfilzomib, lenalidomide, and dexamethasone, that's Kyprolis, Revlimid, and dexamethasone, with a stem cell transplant in high-risk smoldering myeloma and showed that you can get very deep responses in these patients. We are doing a trial called Ascent trial where we are again trying to use all those 4 drugs, the proteasome inhibitor, which is the Kyprolis, the Revlimid, the Darzalex, and the dexamethasone together, and treat patients for 2 years to see if we can actually keep the myeloma under control or even potentially eradicate many of these early myeloma cells. The other area that we are actively looking at is the concept of personalizing therapy for the patient or individualizing therapy. What we know is that myeloma can be quite heterogeneous because of the different mutations and the genetic changes that we see in the myeloma cell. So instead of just using the same recipe for everyone, can we somehow incorporate those individual variations? So what we're going to do in this trial called MyDRUG trial, which is being done through the Myeloma Research Foundation, is to look at the functional, again, patients with high-risk myeloma, meaning they relapsed very early after their initial treatment. We do genetic studies to see what kind of mutations they have, and depending upon the type of mutations, we give them specific treatments that we know works against that mutation. So this is, again, this trial is going through the approval process and hopefully will be up and running in the near future. And we hope that this might, again, be a very different way of looking at myeloma. And so using all these different approaches, potentially intervening early, using multiple drug combinations, and then when the myeloma comes back early, using a more individualized therapy, we hope that we can actually make a meaningful difference in terms of survival for myeloma.